Hi, my name is Dr. Tiffany Inglis, and I am the Medical Director of Clinical Programming within our Population Health area at Elevance Health. I'm also a board certified obstetrician gynecologist, and I'm here today to talk to you about partnering to improve maternal mortality and the outcomes surrounding that for our moms and babies and families. We can go to the next slide. I think as a start, would love to just sort of define the issue when we talk about maternal morbidity and mortality and really understand sort of where we sit. And as many of you know these statistics, I think it is good to ground us in them and then really focus on how do we start addressing them. In the United States, we rank last in maternal mortality among industrialized nations. We sit at about 32.9 deaths per 100,000 live births, and over half of those maternal deaths occur in the postpartum period. There are significant racial disparities for our Black moms, with a 2 to 3 times increased risk of death over our white moms and a greater than 3 times increased risk over Hispanic women. In 2021, we also saw evidence that age is very impactful in this number. For women under the age of 25, we saw about a 20.4 deaths per 100,000 live births. And then when you get up to above 40, the incidence goes to 138.5. So that rate for women aged 40 and over was 6.8 times higher than the rate for women under age 25. So obviously age has a very important component of this. So I think that also shows it's just very multifactorial, right? So there are age impacts, there are race impacts, there are lots of different things that impact that number. Currently, there are quite a few different initiatives around the country set up to try to minimize or reduce what we see around this space in maternal health. And one of those is AIM, Alliance for Innovation on Maternal Health with ACOG. Those have safety bundles that are predominantly hospital-based and focused on maternal deaths and surrounding that pregnancy delivery episode, right? And there's lots of other ones, but that's just one of the ones we were calling out. I think we can go to the next slide. As we think about deaths in this space and for these families, cardiovascular conditions cause about 50% of maternal deaths, including cardiomyopathy, embolism, hypertension, stroke. It is the number one killer of Black women. Suicide and behavioral health disorders is the number one killer of all other women. And that is a large proportion of deaths are attributed to maternal health issues, and overdose and suicide play a big role in that. PMAD, what is PMAD? PMAD is perinatal mood disorders. They are considered the most common complication in pregnancy. About 1 in 7 women are affected. And according to the CDC most recent estimates, about 84% of maternal deaths are preventable. So really then that sort of transitions us to, I think, as we move into the space, it's always important to identify the problem, but I think it's also very important to then move into the space of how do we start to address the problem? What do we think are areas of impact? And how can we start shifting that conversation away from the identification of the issue, and then also move into how do we start addressing it and improving these numbers for our families? So I think we can go to the next slide. And I think there's one last piece, sort of thinking about the scope and the most recent, I would say, trend. And so really from 2019 to 2020, there was a 37% increase in maternal mortality. And if you notice from those breakdowns, it was worse for our Hispanic moms, and their increase was 54% overall. Severe maternal morbidity rose for women about 9% from 2018 to 2020. And Black women, the ages of 35 to 44, so again, the higher race risk as well as the higher age risk, have a 66% higher risk of severe maternal morbidity than white women. So when you really think about that number, it's stark and it's drastic. And so what we have worked hard to do over the last couple of years is really identify where are actionable moments, and then how can we implement things within that healthcare experience to try to shift those numbers and to try to turn that around and improve the lives of all of our pregnant people, but then also make sure that we are improving on those disparity gaps or those health equity gaps that we see within the maternal space. So on the right side of the slide, you'll see there are different areas where we have sort of strategically are approaching this issue and breaking those down into different areas. And I think the first is we call access to care. I think the most obvious one you think of is the maternity care deserts. And we get that report from the March of Dimes, and it's really helpful to understand who amongst our communities is really struggling with access to care within their community. And as more and more hospitals are closing in these rural areas, that becomes a bigger and bigger issue. So how do we start addressing getting people care who maybe live in a space where they're pretty far from their healthcare providers? And so when we think about that, I think there's a few different ways you can approach that. There are digital options. So whether that's self-directed digital education tools, whether that is virtual care that can fit in between the care where you need to be seen in an in-person basis. And I think for COVID, we saw a lot of that happening by necessity. And then I think what we realized is that that might work to really solve some of these issues. There are certain visits you must be seen in person. We really need, that physician or midwife to be able to really kind of examine the patient and do all the things in person. But then I think there's this parts of that care journey we all recognize now, where for women who have access issues, we can really support them in a way where they don't have to necessarily be in person. Those are telehealth visits. But I also think there's access issues in other parts of our healthcare system. So when we talk about even like within an urban environment where we may not see a lack of an ability to have a provider in your neighborhood, some of our women, they struggle with, how do I get childcare? How do I get time off work? I don't have transportation. So there are still access to care issues that come up, even when we might be able to on a map see, oh, well, they have care providers around them. And so it's really important to think about how we address those access issues as well, with transportation supports and childcare supports, and how do we really think about making sure that people have access to the care that they need. And then I think that when I think of access to care, I think of another area. A lot of healthcare traditionally has been very, I would say, one directional, where you see your healthcare provider, they give you a list of things to do, you have to keep track of them all, write them all down, make sure, and then you go turn around and do these things. Well, we don't all learn that way, right? There are a whole lot of people who that's not the way that they process and intake information. And I think in the world of digital, we have the opportunity within healthcare to really allow for those alternative learning and processing ways to be met for our members or for our patients or for our pregnant people within the country. So when you think about a digital application, I could potentially have a video, or I have written content, or I could repeat it multiple times. I could have checklists. So building in all of those sort of capabilities to help people to be able to understand and be a part of their healthcare process. I think when we hear from people who are, especially people at risk of having an inequitable outcome, they will tell you, I didn't feel valued, I didn't feel heard, I didn't feel understood, and I didn't feel like I was a part of my care pathway. And I think the more we can make these things available and open and sort of meet people in a way that makes sense to them and allows them to be able to take in and process information and learn in the way that's best for them, we can really help break down some of those barriers to care and really make sure that they feel like they're part of the plan. And I actually think that leads me to the third point, which is some of the work we've done around doulas, and working to achieve better outcomes through that doula space. And there's significant work there that through Elevance and multiple of our plans with doula partnerships. And it's really been work that is a true partnership, right? So to go back to the topic at hand is, how do we partner to do this? And really understanding that, healthcare providers who are addressing the medical needs of patients and doing that delivery, whether that's a midwife, whether that's an OBGYN, there's a lot there to handle. But we know social impacts, behavioral health impacts, and all these other pieces of the puzzle are equally as important in the member's healthcare journey or in the patient's healthcare journey. So when we think about that, what we want to make sure of, and doulas really support this, is how can we better support the social needs without taxing sort of these medical delivery providers. And how do we help them? And doulas really fit perfectly in that space. They already have community connections. They already understand those that they're often taking care of. They're committed to their communities, and they really have shown to improve outcomes. They reduce C-section rates, improve VBAC rates. They reduce NICU usage in those babies. They improve lactation rates. They also reduce postpartum behavioral health issues. So, and really people say, I felt better supported. I felt like I was better understanding of what I needed. I had a better understanding of what was in my community to help me as I went along. And then I would say within the community programming, it takes you back up a notch to that food as medicine. We know that when we get people healthy, nutritional meals and food and access to food, we see significant reductions in preterm birth rates, both nationally and within our own population at Elevance. But what's really interesting in a lot of the national studies is these food as medicine programs, or things like WIC and SNAP, and people having access to nutritional food, they actually remove those disparities oftentimes that we see along the racial areas. So Black moms who are engaged in a lot of these programs have lower preterm birth rates than white moms engaged. But yet when you get out of those programs, the Black moms have that 2 to 3 times increased rate. So there's something really important about that to be able to really drive reducing the equities within this healthcare space. And I think food as medicine and doulas are two of those that we actually see an impact there. And then from a behavioral health subset, I think the biggest thing, and I think everyone likely agrees, is behavioral health, physical health, and social needs all have this very equal position in affecting outcomes, and really making sure that people are supported. Within our data, when we looked, people who had a network, they had care set up, they had I would say, I call it a net, but they had a care delivery team that was set up before they got pregnant. They have much better outcomes because they really are more supported. And so making sure that people really get the support that they need, building behavioral health supports into the end-to-end maternity solutions, making sure that those moms with substance use disorder are truly supported through all sort of the 3 pillars, right? There's pregnant, but postpartum is a very difficult time for those women, and they really need a lot of support to make sure that they have what they need. It's a challenging time. It's for everyone, and that's really can test someone's success in their recovery. And then also just outside of those 2 spaces, from a women's health perspective, and making sure that they continue to stay connected to community. Your community is so important to remaining in recovery, and really understanding how do we help support that as they go through that life cycle. Another program that we have that's been extremely successful in reducing poor outcomes for moms is actually focused on better supporting our providers. So we have a maternity specialty provider enablement group, and we have significant data regarding how that positively impacts things like C-section, things like preterm birth, low birth weight. And our doctors who are engaged in our value-based care program in Medicaid and have a specialty provider enablement personnel who's working with them and helping to provide them with data, information, a path back into the plan, all of those things have really moved the needle in helping to improve outcomes for those members. So really, it just speaks to the fact that, again, it's that partnership, working with the providers to help get them what they need quickly so that they can better serve the members. Another portion of that program are, we call them OB practice consultants. That's that provider enablement team. And they actually have a very specific program that they're doing right now focused on postpartum impacts. And it's called the Postpartum Maternal Morbidity and Mortality Initiative. And what they're doing there is they have collateral that was created from some things from ACOG and some of the psychological society work, and really helping to give providers collateral that they can easily use with with the patient after they've delivered or in that hospital or postpartum, to review signs and symptoms of cardiovascular and behavioral health causes of morbidity and mortality. And in doing so, it sort of drives that conversation up, right? To say, hey, here's a red, yellow, green sort of stoplight list of things. And if you're experiencing any of these things, call, connect, let us know, right? Don't wait. And really trying to push that conversation to the forefront of like, just because you're done with your delivery doesn't mean you're done with the potential complications that come with pregnancy, and really making sure that that connection through the postpartum care episode continues. And we know people who have postpartum visits on a regular basis tend to have lower rates of problems, and really sort of giving them a tool to help them start that conversation early and often. And then I think some other things that we've seen, um, there's a lot of research on Medicaid and Medicaid expansion. And one of the studies that we did at Elevance looked specifically at expansion of Medicaid and the impact to maternal and child outcomes. And what we saw was not only did it improve outcomes, it improved outcomes for some of our higher risk groups. So it improved outcomes for our Hispanic groups significantly, and improved our outcomes for some of our other moms who are at higher risk based on other data. And so really understanding that by keeping people with their coverage through that life cycle of pregnancies, we often see much better time to care and much better outcomes. I think we've talked a bit about the enhanced digital access and educational resources. By doing that, I think it really, really enables our patients to have immediate access to the educational resources they need. They don't have to wait on a phone call. They can text, they can chat. It's a more direct link to us, which I think is the way we all live. And especially, if we're talking about 20-some-year-old moms, they don't want to call. They don't want to wait on a phone call. And they really want to be able to have easier access to information. And then I'll leave it with one of the other things that we're working very hard to do is really better understand using our insights from our analytics, and a deep, deep commitment to that over the last 3 years to understand who's pregnant, when do we know, how right are we, and what do we know to impact all of those things above. All that data above has driven all these other things to say, okay, what do we need to do to solve that problem? And then really developing interventions or improving the things we already have to make sure that we're getting those moments that matter. It's what I always call them, right? Understanding when can we act to potentially prevent something from happening. I think we can go to the next slide. And I think in this next slide, what we wanted to do is show you a video which highlights one of our amazing doula partners. And again, these partnerships have really driven significant improvements in outcomes. And so we're going to go ahead and have you see this video, which is a great video and talks a little bit about the work that we've done in that space.
From 2018 to 2020, we saw a significant rise in maternal mortality rates, but they rose more for Black women and Hispanic women and people of color. We did a study with the Elevance Health programs in 3 different markets that were early doula programs. And what we found was they were less likely to need inpatient services during their pregnancy. They were less likely to have a preterm birth. And not only does it work for people as a whole, it seems to very much positively impact people of color. I'm Nikki Dawkins. I've been a certified doula going on 6 years now. As a doula, I help people who are pregnant with advocacy, education, and just general support. I think the beautiful thing about doula care is that it's continuous care for the parents. So we're not just there when they birth, but we're also there for them after they birth and before they birth, and pretty much all the things that come in between. Today, we're hosting an event for the moms so they can actually connect with each other after you have a baby, as you tend to lose touch with the world. Doulas themselves are non-clinical. They're really there to be that support structure and to help be the voice and help the member or the person find their voice within their healthcare experience. And also, I think they help build community. And anyone who's had a child knows that needed. Getting them on a path with somebody who was supportive of what they wanted to do made such a huge difference for them. Like literal change in their personality, of how much more supported they feel. I felt supported as a woman. I felt supported as going through it as a first-time mom. What this research has proven to us is that we do need to share it broadly and make sure that everyone understands the value of having access to doulas, whether that's through local access with training and certification, but also through policy around supporting doulas and having doulas be a part of this workforce.
So I think, when we look at doula care, we really think about the ways that, why, right? Why does it matter? And so I think the why we've talked about, right? Poor birth outcomes, significant racial and ethnic and socioeconomic disparities, and they're increasing with time. And so I think you heard some of it in the video, but the biggest things: lower preterm birth rates, lower cesarean section rates, better APGAR scores, more positive birth experience, right? For the moms that are in this, really understanding how they can connect and how they can verbalize what they're thinking and feeling, being supported in that, understanding how to ask the questions they want to ask that they maybe before were afraid to ask, but then also what's available to me in my community, right? How can I'm having trouble getting to my appointments? How do I find help? The doulas often know that very well, right? How do I get I don't have food, I don't have childcare. How do I do this to make sure that I can get to my appointments, eat healthy, and be there for my baby? And I think all of those things sort of really build to what we're looking to do, which is really wrap patients around that support structure and get them that evidence-based clinical care from their delivery provider, behavioral health needs that are addressed and understood, but then also putting on equal footing this need to help support the social need that people have, wherever they may be, and really understanding how as they build their families, how they keep that social support around them, so that they can have the healthiest pregnancy that they want to have. I think we can go to the next slide. And from an Elevance Health perspective, we've sort of taken this comprehensive approach, right? We did this study, we understood very clearly exactly what the positive impacts were, and really started to show that, share that, socialize that, and say, hey, how do we get more doula programs? How do we address the policy and advocacy and make sure that we can get doulas livable wages? We can help get them into the healthcare system in a way that they want to be, which is part of the conversation too, is making sure that we're listening to the voice of the doula and partnering with Nikki and so many others to really understand what are their concerns, what are their roadblocks, and then really understanding how do we support development of doula programs once we do have some ability to be able to bring them into the healthcare experience for the member from the plan side. And in the meantime, how do we build capacity, right? How do we give grants and do the things that we can do to help build capacity, build training, build education, make sure that people have these in their communities, and really understanding too, where are they most effective in helping those who are at highest risk. And then I think furthering our research, looking at, as we've grown these programs, what we're currently doing is how do we review, right, this data and understand that as we've grown and built larger and larger doula impact, what else are we seeing? What else are we doing? And then where do we need to focus those energies as we move forward? So that's a lot of the work that we've been doing in that space. You can go forward. And then from the study itself, basically we evaluated a few years ago this initial study, and like I said, we're just sort of refreshing this right now. Don't have data back yet, but we did the early programs in California, Florida, New York, and looked at Medicaid members who participated in doula pilots in these states. And it showed a 0.65 lower odds of C-section compared to women with similar demographics and clinical characteristics who did not use doulas. Also showed a 0.85 lower risk of having behavioral health diagnosis in the postpartum space. That's specific to postpartum anxiety and depression. So really, really helps the members to feel supported in that space and get them through that time frame. What we also saw is women who started using doulas early, first trimester, had the most consistent reduction in C-section rates. So really important is again, it defined for us, and we've seen this with OBGYN and midwife care too. The earlier we get people to care, the better they do. So it really prioritizes that early identification and then targeted for care. And then lower proportion of low birth weight babies were delivered when mom had a doula. And so that's really important, right? Low birth weight babies, often sign of stress in utero or need or preterm birth, and really understanding that we're driving that for the babies as well. So what does that mean to the baby's long-term outcome? And that'll be some of the work we do as the study gets larger is what does this mean for baby long-term? And then a lower proportion of infants admitted to NICU when they have mom has a doula who's part of their care. So again, not only low birth weight, but then any other cause for maybe NICU admission seems to be reduced as well. And so on the right, those are sort of the KPIs we use for our doula programs and really understanding what can we move the needle on by implementing these programs. And again, such an important piece of why we've pushed to have these programs grow and expand in time. And on this slide, there's a couple of links to some of the research that we have out there and some articles around it. So if anyone needed more detail, it's found in those links right there. We can go to the next slide. And then I think just a last touch base, I talked a bit about our OB practice consultants. This is that provider enablement team. This is a specialty provider enablement team, a little different, I would say, than some of our other provider enablement teams, because these are actually clinicians with maternal child expertise. And their focus is provider collaboration. They have in-person and virtual touch points with providers and the office staff. And they're really focused on quality and gap closure, but also then providing timely and relevant data and making sure that it's actionable. I think if we go to the next slide, it has a nice visual of sort of how they all sit together. I like this visual. It's you sort of think of the practice consultant in the middle. That's the OBPC. You know, again, clinician lives in the health plan level. So, you know, if it was for Georgia, they are in Georgia, and they're really understanding of the enterprise strategic framework around maternity. They're a part of our team. They understand exactly where we're going and what we're building and moving towards. And then they engage with the providers in our network. And so with a provider, they're doing in-person and virtual visits, and the in-network providers, they see at least 16 times a month through virtual and in-person meetings. So that's what they're working on every monthly basis. They meet with each one multiple times in a year. And they really are building consensus and commitment to change. And they're really that touch point, right? So if the provider is having trouble with something, they have a direct contact back into us. So they're not dealing with phone call after phone call. And then they help. Also, OB-QIP is our value-based program in Medicaid around maternity. And so they also help to enable those providers that are engaged in our value-based care program. They do see non-attributed and attributed providers, but they have some more robust data for our value-based care attributed providers, and to really help them understand where they are with real-time data and where they can move forward. They are also a conduit back into the health plan. So as you think about that, if we're not already engaging someone in case management or social support or with one of the benefits that the member already has, the provider can actually say, you know, Tiffany's really struggling and she's not coming to appointments and she's telling me she doesn't have transportation. Do you guys have something that can help her? And so then the practice consultant also is deeply embedded into the health plan and can go back and say, you know, yes, let's get them in case management, or here's our transportation program, or, you know, all of the different things. And then they can also go back to the plan and say, I'm consistently hearing my providers say this. do we need to do something different to help fix that? And then also they can help, they're supportive of all of our doula programs and getting those grant dollars and programs at the local level built and really looking at that. And then they also work very closely with our quality teams. So at the bottom, I think they're just some quotes that some of our providers have given to us over the years. This program's been around for, I don't know, it's about 5, 6, 7 years now. And we've expanded it dramatically in the last year, year and a half, because of all the successes that we've seen. And we just actually got a third consecutive evaluation of the program that we do internally, where we saw significant improvement in outcomes associated with members who are seeing a doctor or a midwife who's in a value-based care program, and that doctor or midwife is supported by a practice consultant through the health plan. We can go to the next slide, because I think it shows those outcomes. So what you see here, just to sort of frame this, at the top part of the graph, and we actually just literally like hours ago got the newest one. So this was the second. These outcomes come from the second of 3 program evaluations, and the third one just came out literally hours ago, and it re-demonstrates all of this. And these are very similar to the first year as well. But an OB practice consultant alone working with a provider who's the member does not have a value-based care attributed doctor is the first line. And then the bottom, the second line, the OBPC plus OB-QIP, those are member outcomes for those members that are working with a provider, midwife or doc, who's in the OB-QIP program. And that OB-QIP provider is also supported by a practice consultant. So there's a 5% savings in total birth costs, 5% savings in maternal first year costs, 9% reduction in C-sections, 91% increase in postpartum visit compliance. And I think when we think back to the beginning of the conversation about disparities and morbidity and mortality, that number right there to me is so important, because that means that people are coming for their visits and they're being seen in the postpartum space, and they're really having that partnership with the provider taking care of them, and they're much less likely to have a catastrophic outcome. And then there's a 22% increase in VBAC, which is vaginal birth after cesarean, which I'm sure is driving significantly that reduction in C-section rates. And this year we've introduced, and this is the first year, and we always, when we do a first year of a measure, we always do it as a bonus measure. What that means is that it's not required. But we are looking at health equity and specific to hypertension, because again, goes back to the cardiovascular causes of death for moms, Black moms being number one. And really that's due to these hypertension and some of these other big diseases that cause big, poor outcomes for our moms and babies. And really looking at how are we able to close the gap for our Black moms and get better, even more improvement in their outcomes and close some of those disparity gaps. I think we can go to the next slide. And this is just some specifics about the postpartum maternal morbidity mortality initiative. I won't read through all of these. This is some of the data behind some of those stats that I gave earlier in the talk. But really, early intervention can decrease healthcare needs, improve health and well-being of both mom and baby. And the studies out there are pretty significant in showing that the evidence is there that if we can just get people earlier to their health care and try to prevent the catastrophic outcomes, we can really improve the life of the mother-child dyad. And so I think if we go to the next slide, it talks a bit about the initiative. And this is just an example of one of the letters that we have in Georgia that goes to our providers to tell them about the program, why we created the program. And this is how our practice consultants really socialize the educational materials. And it goes through the why. Why did we do this? Why do we think this is important? And then if you go to the next slide, this is really about what they are. So this is an example of what they look like for in our Georgia market. And really, you see the red, yellow, green, and one is for postpartum mood disorders. They're actually one piece of paper. One is on the front, one is on the back. And it goes through the maternal cardiovascular health risks, which again, number one killer in Black moms, and the postpartum mood disorders, number one killer in all other moms. And really walks through, here's what you might feel and here's what you need to do if you feel those things. And really, I think starts the conversation. I think so many times people are afraid or they don't know what it means, and so they don't say something. And then as it gets worse, it's harder to prevent that poor outcome. And so really opening up the lines of communication of, this is why I think it's so important that you keep your visit. This is why we need you to keep an eye out for this thing. And if this happens, who should you call, when should you call, and how should you outreach? And so it goes through all of that. And then there's another part to the flyer that has some stuff in the bottom about, for the providers, about who's at highest risk for these things to happen, so how they can prioritize who they're screening for those things. So that's really that program. Good feedback so far from our providers who've really adopted it, and I think it's helped them have a ability. And many of them have just laminated it, and they kind of keep it with them, and it's an easy thing to just show the member, and as they're in either postpartum rounds or in the office, and just have that conversation and start opening that line of communication. I think we can go to the next slide. Next one. So I think the last thing, I think this is one of the last things, but what we're also doing internally is really looking at all of the things we've just talked about, building digitally enabled, seamless member-facing solutions, understanding who our providers are that are really focused on this work and doing good work, and how are they successful, and then sharing that, right? Like they have these great numbers because they've done these things, and then really expanding and highlighting and working on growing attribution into value-based care, but then supporting those providers with these practice consultants and this provider enablement team to really then, from an internal perspective, take our external partnerships and wrap these moms around with solutions, right? So, and providers, let's be frank. I mean, there's a lot asked of providers right now. So if we can have virtual lactation services, and they can have nutrition and dietitian services, transportation services, all these various ways to help support the member with all the things, food, transportation, all of that, really understanding how we make it easy and navigable for them, and not have to try to figure it out on their own. And so that's been a really big focus of ours. I think there's still work to do, but it's really, again, I think it all goes back to, and I say this often when I give these talks, is no one's doing this alone. None of us are going to solve this problem alone. And so it's really about developing our partnerships with our providers, with the doulas, with our community-based organizations, and with the member, to make sure that everyone has what they need to be as healthy as they can. All of us have the same goal. We want a healthy mom and a healthy baby. And so I think in the end, if we can really break down those barriers and try to make this as easy as possible, give people the information in the way that they'd like to receive it, I think we can begin to develop some of that work. And we have. And then this is part of our doula stuff. I think it's just a slide about, some of the ways that we have really focused. We have a couple of phases of doula grants, and there's quite a bit of dollars that we have been pushing out from our foundation, but from our Medicaid plans as well, to really make sure that we're getting more doulas trained across all of our markets, and making sure that they're available to all moms. This doula grant work is really for all moms, and really also focusing on, a lot of these doula organizations are BIPOC owned, and they are run in that way, and they are in communities where we know members struggle with access, and they struggle with being higher risk of poor outcomes. And so really trying to focus on how do we wrap them around and get those supports in their communities where they need them. I think we can go to the next one. And this speaks to some of the breakdown of those commitments. The foundation has given significant dollars to multiple maternal health entities external to Elevance, and really 26 organizations have gotten about $18.3 million of the $30 million that was committed. Early grant outcomes, we're seeing decreased preterm birth rates, decreased maternal morbidity mortality, and decreased primary C-section rates, which sets members up for a lower C-section rate late in the future as well. And really this sort of breaks down some of those early outcomes, and really looking forward to, as these programs grow, having more and more data. But early indicators and early data shows significant impact. And I think what's really also telling is about 90% of program participants are from communities of color and 60% are Black. And so I think it's really about trying to really focus in on, we understand what the problems are, and we now have an idea of how to start addressing those problems, and really making sure that in our communities that need these programs to really close those disparity gaps, that we're making these programs available to our moms, to our providers, and really making sure that they have what they need to take care of both mom and baby and get them a fresh, good, healthy start, which can often mean so much for so long, for the rest of their lives. I think that was it. Oh no, I was wrong. Um, there are some Georgia maternal grantees. So from that work, some of those grantees were in the Georgia space, and just kind of wanted to call out these specific programs and some of our very special partnerships within Georgia. And they really are part of all of those numbers that you see as far as the success rates, and really making sure that we're reducing disparities within the state as well. So there's enterprise work and there's state-based work, and Georgia has been a big partner for us to be able to make sure that we are improving outcomes within your state. And I do think that is it. I appreciate everyone having me today. It's always good to talk to others who care so much about this topic and this issue, and really I think what's most important for me as we move forward is, we spent a lot of time sort of defining the problem, and it is a problem, it's a big problem, and really now starting to say, how do we really start seeing impact, and what we are doing, is it giving us impact? And what we're starting to see is yes, but there's a whole lot more work left to do. And so it won't stop, it will continue to go, and we will continue to try to do that as we go forward, to continually improve these processes. So thank you again for having me.